I'll be talking shortly to Dr. Kevin Kavanagh, a member of Infection Control Today's editorial advisory board and a frequent contributor to our print and online publications. Dr. Kavanagh has been following COVID since the beginning, and his predictions have been right on the money. To take just one instance, Dr. Kavanagh said that COVID-19 will be a pandemic, and a world-altering one at that, using that word pandemic long before either the CDC or the World Health Organization used it. Dr. Kavanagh also said early on that the symptoms of COVID might last a lifetime and they might be debilitating. He told Infection Control today that long before the story was picked up by national news outlets. Now, Dr. Kavanagh will explain to us why the switch in data collection method is such a bad idea, in his opinion. It's akin to changing horses in midstream, and as Dr. Kavanagh puts it, you don't want to switch horses in midstream during a pandemic. My discussion with Dr. Kavanagh coming up. For these and other stories, please visit infectioncontroltoday.com. Hi, I'm Frank Diamond, the managing editor of Infection Control Today. Last week, the government changed the way COVID-19 data is collected. It had been reported to the U.S. Centers for Disease Control and Prevention. Now, with that change, the data will be reported to the U.S. Department of Health and Human Services. That change drew immediate backlash, including from APIC, the Association for Professionals in Infection Control and Epidemiology, and SHEG, the Society for Healthcare Epidemiology of America. My guest today will help explain what all the commotion is about. He's Dr. Kevin Kavanagh, a member of Infection Control Today's editorial advisory board. He's also a frequent contributor to our magazine and to our website. Dr. Kavanagh, as always, thanks for being with us today.
Well, thank you very much, Frank.
Now, you also see this change in reporting method as a very bad idea. Why is that?
Well, the main drawback is you're changing horses in the middle of the stream, and that's not good to do. We are in the middle of a pandemic, and this sort of transition creates a lot of concern, both in the integrity of the data and also in transparency and public evaluation of the data. As you know, we have long advocated for a standardized national reporting system and have received many roadblocks trying to get that implemented. So a change was needed. The question is this the best avenue to take and the best time? And a lot of people are very concerned that maybe it would have been better to fix the CDC and to do this at a time when we're not in the middle of a pandemic. Ready access by the public to this data is crucial. That is the only way we can have checks and balances. That is with good transparency.
Do you buy the government's reason for doing this? Why they made the switch?
Well, from what I've heard, they were concerned with the availability of some of the data analysis, such as whether or not they could get breakdowns by age of patients that are hospitalized. So I think there is some concern that we needed to have more comprehensive data, especially on these pathogens, not just COVID-19, and a national reporting system of all facilities that has adequate case definitions that are the same across the United States. But I'm not sure that in the middle of a pandemic that it's possible to implement a smooth transition. I mean, we're in the middle of a second bump on our first wave that
Right.
we haven't even peaked out yet. And we're going to cut off our data and make it so it's not as clear as what it was before. Does it have to be clear? Definitely. But is this a good time to be doing it? It causes me a great deal of concern.
Now, APEC, as I mentioned, and SHEA, two organizations that represent infection preventionists, they really came out strongly against this, saying that it would cause a huge burden in hospitals. What's the nature of that burden? Just switching systems?
Well, I mean, SHEA and APEC have expressed concerns about burden in the past. One of the reasons why we couldn't get a national reporting system is the burden. Well, the burden has to be just the cost of doing business for these facilities. We not only need this for COVID-19, but we need it for other drug-resistant pathogens. Those are no longer being reported in a lot of cases. And we had a very scant reporting to begin with. I mean, of the CDC's 5 urgent threats, only C. difficile was reported. And of their 11 serious threats, only methicillin-resistant staph was reported. Organisms such as CRE, Candida auris, carbapenem-resistant Acinetobacter, all of those have not been mandatorily reported on a federal basis. And this is a huge concern. Remember, just because you have COVID-19 doesn't mean you won't get a co-infection with another bacteria. If you look back at the Spanish flu pandemic, 95% of the patients that died had evidence of having a co-infection of either Staph aureus, Streptococcus pneumonia, and Haemophilus influenza. Of course, right now, Staph aureus, we have MRSA, methicillin-resistant form. Back then, they didn't have that. And some of our recent studies have shown up to 50% of COVID-19 individuals or patients could have a co-infection. So all of this is concerning. So yes, we do need to have better reporting and a more comprehensive system, but I have not heard yet that that's what's going to be taking place. A lot of people are worried that this is going to result in a lack of transparency and the numbers not being readily available. And this just isn't the number of patients. We also have to remember healthcare workers. They also become infected and at very high rates. And so healthcare workers, they need to be tracked. They need to have compensation. And by compensation, I don't mean paid sick leave. They need to have presumptive disability and workers' compensation benefits from this. And this is extremely important. They need an economic and healthcare safety net. And this, I'm scared, may be just one step into a further obfuscation of the seriousness of this pandemic. So could this be a good thing? The answer is yes. But do we have grave concerns? Answer to that is also yes. I don't think the transition was well outlined on what their goals are, what their end products are going to be for this transition. And that is extremely important because a lot of us are depending upon that data to determine whether or not it's safe to get health care. I mean, I myself need to get health care. I'm going to be having a procedure and going for health care within the next week or so. I would certainly like to know what the rate of COVID-19 is in our areas and which hospitals had the greatest percentage of patients. Because if I'm an elective case, I want to make sure that I'm in a facility that I have the least chance of getting the infection. And that again goes to the concept of that some facilities I feel should be primary COVID-19 facilities, other facilities not. Because let's face it, taking care of COVID-19 patients, especially in an ICU, is becoming more and more of a specialty. We're learning more and more about it. It's rapidly changing, and they have to be taken differently than other forms of respiratory compromise that we've seen in the past. So all of this needs to be done. We need to have data which is readily available to the public and to researchers. And this is what the main area of concern is. Burden, I think, is secondary. Whatever it costs, we need to do it.
As you and I are speaking right now, the change hasn't even been a week. So is there anything different being reported as a result of this change? I mean, is the data still going to be the same data that had been reported before?
Well, the CDC is out of the loop. And I think it's too early to tell whether or not we're going to have the same data. From what I understand, their dashboard has not been updated. And we're kind of waiting around to seeing what data is going to be available and what's not. I mean, the worst case scenario would be that anybody that has a comorbidity or doesn't have a COVID-19 test won't be counted as an infection. Well, as we run out of tests, you're not going to be able to test everybody, especially if someone dies at home and comes in to the emergency room. You may want to save your tests for someone who is currently alive. And this is a huge problem. So we need to make sure that this data is readily available to individuals.
Is there anybody in healthcare, any healthcare profession or professionals who like this change, or have you heard anybody say this might be a positive thing, or has it been basically, what are they doing and why are they doing it?
Well, I think that a lot of people are very concerned about the change. Some that I have heard have expressed, well, you know, this may be a way of consolidating things and to getting a standardized system and getting it more comprehensive, something that the CDC hasn't done over the years. But even those individuals will state, this isn't the time to do it, not in the middle of a pandemic. And it would be far better to get the CDC up and running, get them the resources, they're the experts, and get them transformed at a time when they can further our knowledge of this virus and this infection. The other thing I should state is that the timing of this change is somewhat suspect. As you know, it's at a time when the CDC has tried to push back on the administration, becoming more independent on the school guidance, etc. And that also raises some concerns of individuals in the scientific community. These are just concerns, nothing that's concrete. And of course, those are opinions, but all of this is very, very concerning. One would really have liked to have had someone state, here are our goals, here's what we're going to accomplish, this is what we're going to do, and this is why we're doing it. And this type of detailed explanation just wasn't there. And so that's what is raising the red flags.
You said that it would have been better to bring the CDC more up to speed. Is there an implication there that the Department of Health and Human Services can do things with data collection and data interpretation that the CDC can't do now?
I don't really think so currently. I think you'd have to invest, of course, in expanding their system, but you need to realize that the pushback on reporting and standardized reporting wasn't the CDC and federal level. It was our healthcare system that we're stating it's too burdensome. I mean, that's where the pushback came from, was on the facility level and getting the facilities to report, and the CDC doesn't have statutory authority to demand this. Certainly CMS does. So the Department of Health and Human Services may have the statutory authority to try to implement these changes, but they certainly could do that with the CDC being the mechanism to receive the data, because they're already set up to do this.
Anything else you'd like to add about this reporting system change, Doctor?
Well, only that we need to follow it very closely. We need to see what goes up on the Department of Health and Human Services website, how timely the data is, if we can identify what, the data on hospitalizations and ICU utilization, which is really key data. Death rates are not as valuable now that we have some treatments for it. It's mainly if people are hospitalized and severely sick, we want to know how many of those individuals they are, because they're at extreme risk of having lasting sequelae. And so this type of data is important, along with our hospital bed utilization. So all of this needs to be made public and be transparent. And we're just going to have to wait to see if it is. And this type of a pause in the middle of a peaking pandemic, I don't think too many people would think that's a wise idea. If anything, this should be done many, many months ago, even before the pandemic hit.
I was about to ask you, will there be any point in the future, would it be possible to be any point in the future where you might sit back and say, well, this turned out to be a good idea. What would need to happen for you to say that? But it seems like the fact that there was a pause, it'd be pretty hard for you to say that, right? I don't want to word you.
Well, I think you could say overall the system may be a good idea, but the implementation could have been better. And when there is a pause in data, you have a risk of doing unnecessary harm. And so we'll just have to wait and see what happens. I do think a change was desperately needed. I think that the CDC was not the problem on not gathering the data. From my perspective, it was more the problem of the healthcare system in general of being very resistant to making this data available. I mean, even the state health departments didn't have access to NHSN data in a timely fashion unless the CDC gave it permission. I mean, that's how the statutes read. So there are a lot of fixes that need to do. That needs to be a concept that this data is society's data, that is a national security data that we need for the United States, and it's not the property of the healthcare system. Now, the healthcare system is going to say, oh, it is. We're going to determine who sees it, but we need to get past that. This is a very serious pandemic, and it's showing where we really need to have some transformation in our system.
Dr. Kevin Kavanagh, as always, thank you for visiting us here at Infection Control Today.
Oh, thank you very much, Frank.